Okay, for human coronaviruses, the numbers are listed here, have been known to cause worldwide seasonal respiratory outbreaks manifest with generally mild cold or flu-like symptoms for a number of years. Children have been more commonly infected with these cold viruses than adults. It's interesting to note that the coronaviruses are single-stranded RNA viruses, similar to influenza virus, but the influenza virus is multi-segmented, so it is very prone to mutation. The coronavirus can mutate, but it does not occur as commonly. Two novel human coronaviruses, severe acute respiratory syndrome or SARS, and Middle Eastern respiratory syndrome called MERS, emerged a decade ago with severe lower respiratory disease and high mortality in children. Children were uncommonly infected and had generally mild disease. These two viruses were considered to be mutations of one of the human coronaviruses. Next slide, please. Thank you. In 2019, a novel human coronavirus, SARS-CoV-2, emerged in China, and again, it was a mutation and progressed to cause a worldwide pandemic of severe respiratory disease called COVID-19, with a high infectivity and mortality in adults and an incubation period of 5 to 7 days. When the coronavirus mutate, they usually mutate in animals or birds. And this particular coronavirus is thought to have mutated in a bat. Approximately 2% of cases are in children. Initially, children were generally found to be less frequently infected and have more mild disease. The decreased frequency of pediatric infections may be a manifestation of less exposure except via family clusters. Children and adults may transmit this virus asymptomatically. Next slide. Thank you. The pathogenesis of COVID-19 disease is a little bit unique. It's a combination of viral effects and the inflammatory response. If you take a look at this little figure, the viral replication results in cell death mediated by CD8 positive cell killing and pretty much mediated and eliminated by normal host viral responses. A hyperinflammatory response is induced and may progress to the cytokine storm, resulting in multi-system inflammatory syndrome. We do not understand why the human host responds in this fashion to these coronaviruses. And this inflammatory syndrome takes a couple weeks to develop, and it is almost always developed after the virus is no longer around. Next slide. Initial symptoms of COVID-19 disease in children are listed here, and the percentages indicate the most common symptoms. And if you note these symptoms, they're essentially and generally mild and flu-like. And that's their pattern. Next slide. Diagnostic studies for COVID-19 disease in children are not uniquely diagnostic. They include lymphopenia, increased liver and muscle enzymes, elevated C-reactive protein, elevated sedimentation rate, increased procalcitonin, ferritin, and D-dimers. All of these laboratory tests reflect the immune reactivity of the virus. Radiologic studies are indicated here. 65% of chest x-rays show patchy infiltrates consistent with viral pneumonia, but severe lung involvement in children is rare. Chest CT scan may show nodular ground glass opacities. These nodular ground glass opacities are a manifestation of a necrotizing pneumonitis, which is very common in adults and really can be the cause of death, but is not as common in children and not as severe in children. Next slide. Specific diagnostic testing for the virus, SARS-CoV-2, that causes COVID-19 disease in adults and children, is the virus isolation is the most accurate way to document infection. PCR antigen testing measures viral fragments and thus can be positive in the absence of infectious virus. And this is kind of a source of error of positive PCR testing. Antibodies generally target the spike and nucleic capsid proteins of SARS-CoV-2 virus. Next slide. IgM and IgG antibodies arise nearly simultaneously in serum, excuse me, within 2 to 3 weeks after onset of COVID-19 disease symptoms. The presence of either IgM or IgG specific antibodies implies previous but not current COVID-19 disease. Only neutralizing antibodies necessarily imply protection. This is very important for vaccine development. There are a lot of antibodies formed in response to the virus, but they're not all neutralizing. And we really don't understand what exactly the pattern or the development of neutralizing antibodies is. And we need to understand that better before we can develop or at least rely on a vaccine. Next slide. Sensitivity is a measure of how many people who have antibodies will actually test positive. Specificity is a measure of the ability of the assay to test negative in those who did not have the targeted infection. False positives occur when a test result indicates an infection in a patient who was never infected. Lack of specificity of the test. False negatives occur when a test fails to indicate a previous infection in a subject who was actually previously infected, and that's a lack of sensitivity. Next slide. The clinical patterns of COVID-19 disease in children are listed here. Excuse me again. 15% are asymptomatic. 51% have mild symptoms, fever, fatigue, myalgia, and cough. These really are not the symptoms. There's the symptoms of the viral infection, not the symptoms of the immune response. 39% have moderate symptoms with mild pneumonia with abnormal chest findings. This is also a manifestation of the viral infection and not the immune response. 5% have severe symptoms, dyspnea, central cyanosis, and hypoxia. This again is a manifestation of the necrotizing pneumonitis seen mostly in adults and occasionally in children. 0.6% are critical disease, manifest as multi-system inflammatory syndrome with acute respiratory failure, shock, and multi-organ dysfunction. This is a manifestation of the hyperimmune response. Next slide. Immune-mediated complications of COVID-19 disease in children follow the onset of symptoms by 2 or more weeks, as we indicated in one of the earlier slides. Viral antigen tests are often negative when complications occur, indicating that the virus is already gone. Toxic shock syndrome, which is sometimes confused with COVID-19 disease, is not part of COVID-19 disease. Kawasaki's disease is also not part of COVID-19 disease. Kawasaki-like disease is not the same as Kawasaki disease. It is better known as the multi-system inflammatory syndrome in children and adults with COVID-19 disease. In children, the C indicates children. Cytokine storm is an unregulated secretion of cytokines and may be genetically determined. Cytokine storm is part of toxic shock syndrome, part of Kawasaki disease, part of Kawasaki-like disease. The common denominator of the immune responses at least the adverse immune responses in these syndromes is innate immune dysregulation. Next slide. The immunology of COVID-19 disease is summarized here. The angiotensin-converting enzyme 2 receptor expression mediates cellular invasion. And this is from the word go, when the virus is still around. The spike protein binds to the receptor on lung alveolar cells, vascular endothelial cells, monocytes, and macrophages. The triggers of innate immunity follow these binding, and this includes the release of pro-inflammatory cytokines and chemokines, macrophage monocytes and neutrophils, and virus particles and intracellular products of lysed infected host cells. All of these are trigger of the innate immune response. This innate immune response progresses to tissue injury and organ dysfunction. Next slide. Why children may have less symptomatic COVID-19 disease than adults. There's some evidence of less expression or function of the viral spike protein receptor ACE2 in children. And an interesting phenomenon is that natural IgM antibodies are produced by innate B cells in young immune-naive children. These cells are not found in adults. And this is a remarkable difference between children and adults, and has important implications. These cells respond to novel antigens, so they're not memory cells. These immature B cells have the ability to secrete anti-inflammatory cytokines such as IL-10, which may reduce the destructive necrotizing pneumonia seen in adults. So this is a unique protective response in children. Next slide. I'm going to just mention toxic shock syndrome, not because it's part of COVID-19 disease, but sometimes people confuse toxic shock with COVID-19 disease. Toxic shock syndrome happens when specific staphylococcal or streptococcal bacterial toxins act as superantigens, which cause an exaggerated and overwhelming immune response. And that's the cytokine storm, which is part of toxic shock and the other immune phenomenon that we've discussed. These superantigens bypass normal antigen presentation by binding to class 2 major histocompatibility complex molecules, inducing massive cytokine release from both T cells and macrophages. The release of pro-inflammatory cytokines may be substantial, and because up to 20% of T lymphocytes can become activated by a superantigen. This compares with approximately 0.01% of the T cell lymphocyte pool that will respond to a specific antigen. Next slide. Kawasaki disease is also not part of COVID-19 disease, and there is some confusion between Kawasaki disease and the Kawasaki-like disease. Kawasaki disease is an active systemic inflammatory is an acute systemic inflammatory vasculitis of children. It was described 50 years ago by Dr. Kawasaki. It involves multiple organs and tissues. It's also known as mucocutaneous lymph node syndrome. It is the cause of coronary artery aneurysms, which is the major complication of Kawasaki disease. And it is the most common cause of acquired heart disease in children in the United States currently. It affects healthy children 6 months to 5 years of age with a genetic predisposition in Asian children. It's rare in children less than 3 months of age who seem to be protected, presumably by maternal antibodies. It's also rare in adults who are presumably protected by antibodies acquired during childhood to a common mild respiratory pathogen. Next slide. The immunology of Kawasaki disease is described here. may be triggered by an infectious agent. The evidence for this is winter and spring epidemics, history of antecedent mild respiratory illness, cytoplasmic inclusion bodies consistent with aggregates of viral protein, which are found in bronchial epithelial cells. There is innate but not uncontrolled immune responses involved with Kawasaki disease. So the cytokine storm is not part of Kawasaki disease. CD8 T lymphocytes are predominant over CD4 T lymphocytes in the inflamed arterial wall, which is consistent with immune response to an intracellular pathogen. IgA plasma cells are predominant in the arterial wall and respiratory tract, a highly unusual finding, which is not completely understood at present. There's good response to IVIG as an immune modulator, and this seems to be characteristic of Kawasaki disease, but not universal. Next slide, please. Manifestations of Kawasaki disease. Fever persisting longer than 5 days. Erythema and cracking of the lips, strawberry tongue, and erythema of the oral and pharyngeal mucosa. Bilateral bulbar conjunctival injection without exudate. Maculopapular diffuse erythema or erythema multiforme like rash. Erythema and edema of the hands and feet in the acute phase, followed by periunguinal desquamation. And cervical lymphadenopathy greater than 1.5 centimeters in diameter, usually unilateral. And as we've mentioned, the somewhat unique coronary artery aneurysms. Next slide. I'm going to show you a few slides from my collection of kids I've taken care of over the past 50 years. Here's a child with redness and cracking of the lips. Next slide. Here is another child with strawberry tongue. We didn't make it look like a strawberry on purpose. It just looks that way. Next slide. Here is a youngster. This happens to be an Asian youngster of Asian extraction with conjunctival effusion of the blood vessels, and so this is a conjunctivitis, but there's no exudate. Next slide. Here's a little girl we took care of, and she shows the heterogeneous erythema multiforme like rash. You can see she's not very happy. Next slide. This is another boy of Asian descent who has swelling of the palms and a characteristic erythema over the knuckles. Next slide. And this is an older boy who's recovered from Kawasaki disease, and you can see the peeling, superficial peeling of the soles of the feet. Next slide. And the last of these pictures is an older child that's also recovered from Kawasaki disease, and you can see the periunguinal desquamation. This is almost pathognomonic of Kawasaki's, but not 100%. Next slide. Now, getting on to multisystem inflammatory syndrome in children. This is a phenomenon of COVID-19 disease. It's called COVID-19 associated Kawasaki syndrome. It's separate from Kawasaki disease and is better labeled as MIS-C. These children have fewer of the previously defined Kawasaki disease manifestation with more prominent ARDS, acute respiratory distress syndrome, and shock. Kawasaki disease typically affects infants and young children. The median age of Kawasaki's is 2.7 years. Most MIC cases occur in older children and adolescents. The median age is 9 years. The children of African ancestry may be disproportionately affected by MIS-C. By contrast, classical Kawasaki disease has a higher incidence of in Asian children. And these are some of the differences between Kawasaki disease and or multisystem inflammatory syndrome and Kawasaki disease. Next slide. The immunology of multisystem inflammatory syndrome in children. is interesting. The syndrome, also referred as macrophage activation syndrome and hemophagocytic lymphohistiocytosis, results from an exaggerated innate immune response and progresses to cytokine storm. And it's obviously the onset of this phenomenon is in response to SARS-CoV-2 virus. Most affected children have negative polymerase chain reaction testing for SARS-CoV-2 virus, but have positive IgG serology. These findings that further support the impression that MIS-C is an immune response that occurs after the acute infection has passed. Next slide. The manifestations of multisystem inflammatory syndrome in children are different. They're somewhat unique. The fever is the same, and it's defined as greater than 38 degrees centigrade for 24 hours at least. There is shock. There's myocardial dysfunction. There's respiratory failure, kidney injury, serositis, some pleural, small pleural, pericardial, and acidic effusions, hepatic failure, non-purulent conjunctivitis, very similar to what you see in regular Kawasaki's disease, mucositis, also similar, and rash, also similar. There's gastrointestinal involvement, including vomiting, diarrhea, ileus, and bleeding. There's neurologic findings, including headache, seizure, stroke, and aseptic meningitis. And there's a coagulopathy resulting in thrombotic complications, but not coronary artery aneurysms. The asterisks indicate those symptoms that are not part of usual Kawasaki disease manifestations. And it's one of the ways of telling MIS-C from Kawasaki disease. Next slide. The immunology of cytokine storm. It's excessive or uncontrolled response of pro-inflammatory cytokines and tissue injury-related enzymes, which result in excessive uncontrolled inflammatory responses preceding rapid deterioration of the host, suggesting a storm of disease. Major cytokine mediators include interferons, interleukins, chemokines, colony-stimulating factors, and tumor necrosis factor. These cytokines play a central role in innate immunity, but they are exaggerated. Innate immunity can be a normal phenomenon, but they also affect cell differentiation, cell activation, and cell migration. Next slide. Excessive cytokine production results in end organ damage, including to the heart, lungs, kidneys, liver, blood vessels, and GI tract. Cytokine vasculopathy increases vascular permeability, the formation of fibrin thrombi, diffuse intravascular coagulation, and large vessel thrombosis. Again, but not uniquely coronary artery thrombosis. All of these are linked to multi-organ and multi-system failure. Next slide. The manifestations of cytokine storm really overlap with MIS-C because they're part of the pathogenesis of MIS-C. Onset is delayed, as we've said, to later stages of or even recovery from COVID-19 disease. There's unrelenting fever. There's variable rash, conjunctivitis. There's peripheral edema, extremity pain, acute respiratory distress syndrome, gastrointestinal symptomatology, warm refractory shock, and pleural pericardial and acidic effusions. Echo bright coronary vessels, but again, not coronary vessel aneurysms. So you can see that these overlap with the manifestations of MIS-C, which is logical because the immune component of MIS-C includes the cytokine storm. Next slide. Conclusions. COVID-19 diseases in the child present with variable clinical forms from asymptomatic to very severe. The immunology of these clinical forms is different and complex with many unknowns. We really don't understand why this particular virus is so commonly associated with a hyperimmune responses. We don't know if it's genetic. We don't know if it has something to do with the unique characteristics of the COVID SARS-2 virus. Cytokines and innate immune responses play a major role in the pathogenesis of COVID-19 disease, as we've mentioned several times. A better understanding of the pathogenesis of COVID-19 disease and ways to prevent its development by immune-based therapy will be important routes for the future research. And I'm sure you've heard about the use of the plasma for treating COVID-19 disease and the use of dexamethasone for treating COVID-19 disease. We presume that these in part have to do with immune therapy. Next slide. To summarize the immunologic relationships, take a look at this slide. COVID-19 disease in children can lead to multisystem inflammatory syndrome. Innate immunity can precipitate cytokine storm, which is part of toxic shock and MIS-C. Innate immunity, but not cytokine storm, is part of Kawasaki's disease. Thank you.